Good evening. Thank you for joining us for tonight's educational webinar on foot and ankle injuries. Tonight's speaker is Dr. Jeff Gittins, OrthoNeuro Fellowship trained orthopedic surgeon and sports medicine specialist. Dr. Gittins is a board certified orthopedic surgeon with specialized training in sports medicine and adult foot and ankle reconstruction. Dr. Gittins has served as a team physician for many high schools and universities, currently serving as the team physician for Johnstown Monroe High School and Northridge High School. Please type questions in the Q&A box below, and Dr. Gittins will answer questions following his presentation. Dr. Gittins?
Well, thank you. Get this talk full. Thank you guys for spending some time with us here. This first talk we're going to do, I have two available, but we're going to do the first one on Achilles tendon repairs after rupture. A newer technique is endoscopic repair. We're going to talk about different ways of taking care of Achilles tendon ruptures. We seem to be having more incidents of these, especially with some new sports we're playing outside and the weather's getting warmer. So we'll kick off this talk, and I'm happy to take a lot of questions and comments that you guys might have at the end of this conversation. These are my disclosures. As we talk about Achilles tendon ruptures, we want to talk about several aspects of it, including the anatomy, and make sure everyone understands what the Achilles tendon is, what muscles are involved. We want to know who tears their Achilles tendons, who are the people most at risk. Then we also want to kind of get into the meat of it. How do you take care of an Achilles tendon rupture? Is it casting, which is conservative care, which is kind of a nuance these days, versus surgical? There's different types of surgical repairs you can do as well. There's a traditional repair of the Achilles tendon, and that brings in a different aspect of what does that mean. Tonight we're talking about Achilles tendon ruptures versus different means of repairing the Achilles tendon because of chronic issues, whether it be through Haglund deformities or what we call Achilles tendinopathy, which is a chronic injury pattern to the Achilles tendon itself, not a true traumatic rupture. And then obviously we're going to lean more on the endoscopic repair and talk about that a little bit more, and talk about the risk of any type of Achilles tendon repair. We start off with the anatomy. The calf muscle connects through the Achilles tendon and attaches to the calcaneus, otherwise known as the heel bone. The calf is known as the gastrosoleus complex or the triceps third. The anatomy itself is fairly common. Most people know what their calf is, but no one knows exactly what it is. Well, the triceps is composed of a soleus muscle, which is a smaller muscle that goes down the middle of the calf, and it's bordered by a gastroc muscle on either side of it, both medial as well as lateral gastroc muscles. These three muscles blend together to form the Achilles tendon. The Achilles tendon is the most important motor unit of the lower leg, and it's responsible for 90% of plantar flexion energy in normal gait. And injury to the Achilles tendon is also one of the most common sports injuries and can lead to major disabilities. The lifetime accumulative incidence of Achilles tendinopathy can be up to 50% in elite athletes. So those people who are high-end athletes, they still get Achilles tendon injuries, over 50% of them. The watershed zone is the region of 2 to 6 centimeters from the proximal to the insertion where the Achilles tendon has limited blood supply, making it prone to injury. So if you go up from your heel where the Achilles tendon inserts anywhere between 2 centimeters up to 6 centimeters, that's considered the watershed area. That has a poor blood supply to it, and it makes it risk of injury from a chronic small injury or micro tears, if you want to call it that can lead to a traumatic injury called the rupture of the Achilles tendon. The Achilles tendon itself is the strongest tendon in the human body. It can go up to 12.5 times body weight in certain running activities. The maximum tension on the tendon occurs in the late stanza phase. The calf accounts for approximately 90% of the energy in plantar flexion. The viscoelastic property of the tendon allows storage of energy in the stretch recoil cycle while losing approximately 10% as heat. And flexibility of the gastroc soleus complex unit is essential in order to allow the required ankle dorsiflexion 10 degrees in the late stance phase. Achilles tendon rupture is one of the most critical injuries to the lower extremity, especially for higher demand individuals. 32% of NFL players could not return to play in the same league after such an injury. So it's a very important structure, especially for those athletes that are high end. The treatment of Achilles tendon ruptures still remains controversial. So who tears their Achilles tendon? It's most common in men, anywhere between 30 to 50 years of age. I usually use the age range around 40. So whenever I see someone with Achilles tendon rupture, I can kind of take a quick glance at their age on the chart. They're usually going to be right around 40 years of age. It's a 4-to-1 male over female ratio. They tend to be weaker and warriors. Sometimes they're coming in, they started a new sport or a new activity, and that's when they tear their Achilles tendon. But I've also had people who have been active all their lives doing a certain sport, and they can still tear their Achilles tendon doing the same activity. It's a higher prevalence in sports, including basketball, tennis, soccer, running, and the new sport these days, pickleball. It's age related, the tendon degeneration of some type usually. So people that come in with Achilles tendon, we went back and looked at them and we did some soft tissue pathology results. We found out that in addition to they have acute injury to the tissue from the rupture, but they also had chronic injury going on to the Achilles tendon, which we suspect led to the Achilles tendon rupture, or at least increased their risk of having an Achilles tendon rupture. The sudden increase in training or new activity can propose to someone with an Achilles tendon rupture. Medications also can be complicated because fluoroquinones, otherwise Cipro, is a very common one, but also steroid injections in and around the Achilles tendon can increase the risk of having a tear or a rupture. And this still goes on today, even though we as orthopedic surgeons try to educate people as much as we can. There are still people doing steroid injections around a tendon or into a tendon, and that's very, very frowned upon because it can lead to a tendon rupturing. This is an MRI scan of an Achilles tendon rupture, and you can see the white area. That's an indication of a void or actually hematoma, a collection of blood after the tendon is ruptured. The black structure, which goes down to the heel bone, seen on the far right of the picture, that is the Achilles tendon. That's the distal stump. The proximal is actually shortened down and pulled up towards the calf muscle. Usually this occurs with a forceful push-off mechanism or landing. The rupture can occur anywhere between 2 to 6 hours from the insertion site, and this is where the blood supply is the weakest. And this is a really good picture of where that watershed zone is. Symptoms include history of sharp pain at the tendon or heel area, and they relate being struck or kicked. Most often the patients will come in and say, I was playing basketball and I was running on the court and I felt like someone came and hit me with a baseball bat behind me. And they turn around, there's no one behind them, but yet they're on the ground holding their leg and they can't walk very well because they just tore their Achilles tendon. Positive Thompson test, that's the test that most people are going to look for. A Thompson test is when someone's laying on their belly with their feet off the table and you squeeze their calf, and someone who has a Achilles tendon intact, their foot will pulse up and down because the structure, like the wire, if you will, is connected from the calf to the heel. But if you go to the side that's ruptured and you squeeze their calf, that cable is no longer connected anymore, and so their foot won't move. It's an indication, a clinical sign that the Achilles tendon has been ruptured. The question is how much has been ruptured, and that's why we usually go to MRI scans or ultrasounds to find that out. They have an inability to raise up on their toes, which is another clinical sign of a rupture or even a partial tear. They also have a palpable gap at the tendon. If you push and palpate on their tendon, there's a gap, and a lot of times this is what's uncomfortable for the patient as well. So these are the modalities that we look for. We look at x-rays. When I'm looking at x-ray, I want to know if there's any calcifications going on, and that's simple and straightforward to look in the office for an x-ray. I also want to know if there's any type of bone that's been ripped off with it. But then we usually move on to MRI versus ultrasound. What I'm looking for with MRI scanning is how much is the tendon torn? Is it complete ruptured? And then secondarily, I want to know how far has the tendon separated from itself. Has the tendon been pulled up proximally into the calf muscle? And how much distance do I have to close the gap, if you will, between the tear? The sural nerve is a very important structure, and it's one of those structures that we have to be aware of if any type of injury pattern, because it can get stretched. The injury can lead to numbness to the leg. But if we're doing a surgical approach, we also know where the sural nerve is. So it runs down through the middle of the calf. It's connected by 2 different nerves, including the sural communicating branch as well as the medial surocutaneous branch, and these form the sural nerve. The sural nerve comes out after the gastrocnemius complex, and it goes to the outside part of the foot as well as ankle, and it's the outside part of the foot. So when you're thinking about an Achilles tendon rupture, you want to know where that sural nerve is. It's usually on the outside part. I say usually because anatomy can be upset when we have trauma to it, including an Achilles tendon rupture. So that nerve can get pushed or placed in different positions. You want to know where that nerve is, because that's one of the most common complications with any type of Achilles tendon repair is the sural nerve can be injured. As we talk about repairing or taking care of Achilles tendon ruptures, there's 2 different ways, whether it be conservative care versus surgical. Conservative care means non-operative. And so conservative care is best within the first 24 to 48 hours after injury. There's several papers out that people like to quote at this point in time about how conservative care is doing just fine for those patients who have an Achilles tendon rupture. But what gets failed to be mentioned is on those cases that are treated conservatively, those patients need to be seen within 24 hours after their injury for them to be placed in a cast and treated conservatively. But a lot of times we're not seeing patients in the office for a week or sometimes 2 weeks, and those patients are not great candidates at that point in time to be treated conservatively because we can't control the gap between the Achilles and the rupture. So conservative care is best for those older and less active or poor surgical candidates. Those patients who are not great candidates to go to surgery, then conservative in a cast position with the toes down is one of the better ways of taking care of those people. The cast itself is changed every week, bringing the ankle into neutral position. So the toes go down initially, and then every week we bring the toes up into a neutral position as much as we can, allowing that Achilles tendon to heal. But this also avoids surgery. As we continue with conservative care, it's a weaker tendon in the end. It has less strength if it heals conservatively, but it's most likely to tear again in 10 to 50%. It doesn't run the risk of wound complications, however, but they will be in a cast and eventually in a boot for quite a while. When we move our attention to surgical, there's several aspects of surgical repair that can be completed for Achilles tendon rupture. Traditional way is an open procedure where you make an incision in the back of the Achilles tendon down to the heel. You find the tendons, you clean up the tendons, and you repair it directly. The problem is it can lead to a wound complication. That's one of the biggest reasons why people don't like doing that these days, because of the wound complications occur. We can get the Achilles tendon to be repaired, but we have trouble sometimes controlling the wound itself. It's usually stronger if repaired. Between those who have a surgical repair, 3 to 5% go under re-tear. So it's not as much as the conservative aspect. With repairing the Achilles tendon, usually we can get patients back to playing sooner. And there's an asterisk behind that, because the question is, well, back to playing, what type of sport, how high end of an athlete are they? Are they a recreational athlete? Are they an athlete at all? So when we talk about Achilles tendon repair, there's different means, including endoscopic surgery, which has benefits including minimally invasive. It's well recognized. There's less perioperative pain, and there's less scarring. If you look at the picture that we have here, the scar itself is left over from an open Achilles tendon repair. The scar itself is very hypertrophic. It has irritations to it. The skin is all dried out, does not appear to be healthy. And this one can sometimes be range of motion restriction, but also can be uncomfortable for the patient as well. With endoscopic repair as well as open repair, there's minimal blood loss, and they do have a faster recovery. The traditional way is an open procedure, just like I described. Here we're using a modified crack-out stitch where you're running a suture up on either side of the tendon on both stumps of the tendon itself. This allows for a very strong repair and able to reapproximate the ends, but sometimes there can be some gapping in this area itself. But again, this wound can have complications. Surgeries around the Achilles tendon can lead to catastrophic complications of wound healing, including wound dehiscence as we described here. But when we try to do things endoscopic, as the picture showing you here, these are small poke holes, can lead to better cosmesis. You can also have a strong repair to the Achilles tendon. The risks of open repair, well, the surgical treatment was found to have a smaller re-rupture rate. High wound complications were also present, as is once again depicted here. This is a different type of technique for endoscopic repair. And really, this is not an endoscopic repair. This is a minimally invasive type of repair. The difference between an endoscopic repair and a minimally invasive repair is that this one has a small incision, so do endoscopic repairs. But with endoscopic, I'm able to put a camera up into the tendon sheath, and I visualize where my needle is going across the tendon that's been ruptured, and I can follow my sutures out. But most importantly, I'm looking for the sural nerve. I want to know where that nerve is. The advantage of doing an endoscopic repair where I have a visualization of it, I can place sutures across as many times as I want to find good tissue that I feel is good tissue to cross the suture over in that plane. With this minimally invasive technique, with this certain guide here, it's set. You pass sutures back and forth, and it's set. You're not visualizing the nerve, and you don't know what's good tissue or not tissue. You don't know the depth of the sutures you're placing. And again, the nerve is at risk. These are pictures of endoscopic technique. These actually are small little incisions placed on either side of the Achilles tendon, where needles are passed through the Achilles tendon, and then once again the sutures are passed out. And when it's all said and done, you make multiple passes through the proximal stump, and then you make multiple passes through the distal stump, and you're using 2 different sutures when you do this. And when it's all said and done, you tighten down the sutures themselves, and it acts like for lack of a better term, a Chinese finger trap. They're locking sutures, they pull across and they grasp the tendon itself to bring it down to the suture site. And by doing so, you have a firm grasp on the tendon both proximally as well as distally and giving you a very strong repair. This technique is not for everybody. As orthopedic surgeons, we are familiarized with endoscopy overall, but the use of endoscopy is still limited in parts of the foot and ankle, and this is one of those areas. It is a new technique. It is technique dependent, and so people have to be trained. And so advanced techniques in foot and ankle arthroscopy courses are out there for people to learn how to do this. But once again, not all orthopedic surgeons feel comfortable doing endoscopic Achilles tendon repairs. Here's some of the results about endoscopic Achilles tendon repairs. Velocity reported comparable satisfactory results. The results were in strength, return to sports, and subjective symptoms for both the percutaneous repair group and the endoscopic suture repair group. The lower re-rupture rate in the endoscopic group was attributed to the ability to control the adaptation of the tendon ends. Very good investigative use of endoscopy-assisted Achilles repairs in a series of 11 patients without complications. The average return to daily activities was 10 to 11 weeks. And again, this is only 11 patients. They don't have a very strong number of patient reports out there because there's not that many people that are doing endoscopic repairs. They were outperforming endoscopically-assisted repair in 62 patients with 100% satisfactory results with a mean AOFAS score of 94.6. So they did fairly well. 95% of patients returned to the previous sporting activities, and that's a very good result. And 2 patients experienced transient hypoesthesia of the sural nerve that was resolved in 6 months, meaning the nerve became numb after the sural procedure because somehow it got pressure or it pulled or tugged or in close with one of the sutures, but that typically did resolve within 6 months. Tang reported all good, excellent clinical scores without complications in 20 patients using endoscopic assisted repair. And so conclusion, the endoscopic Achilles tendon repair is a safe and reproducible technique for repair of Achilles tendon rupture. Thank you. Are there any questions?
Yes, we have questions. So the first question is, can you walk after you tear your Achilles?
So that's a loaded question. The answer is if you tear your Achilles tendon ruptured, it depends on how much is it torn. So if the parts are tear, yeah, you can walk into the office. That's the problem. I've had people walk into the office with a complete rupture of their Achilles tendon. When you have your Achilles tendon repaired, the different techniques may prevent you from allowing to walk on your foot initially. So if it's a conservative care, you're not going to be able to walk on your foot because your toe will be plantar flexed all the way down for several weeks, and as we slowly bring it up, because we don't really let you walk out at the same time. And so that is one of the benefits of surgically correcting the Achilles tendon rupture. If I can repair it as a strong repair, I can let the wounds calm down initially for possibly 10 days, 2 weeks, and then I can get you walking out, because I have to be careful about the wounds before I let you start walking on. But usually the repair is good enough as long as you're protecting the boot to be able to get you walking sooner versus later. And so the benefits of surgery is actually to get someone being active again. So we don't run the risk of having people not walking. If they don't get to be able to walk, then they sometimes get weaker or they get sicker actually. And so it's a concern.
Do you have to have surgery with a complete tear?
Again, the answer is no, you do not have to have surgery if you have a complete tear. So that can be treated conservatively. But some people have weakness after that type of technique of repairing it. I've had people come in who have never had any type of care after they completely ruptured their Achilles tendon, but they've also had degeneration of that tendon as well, leading to a bunch of scar tissue in the tendon, and they became dysfunctional. They're very, very weak. They had discomfort, and then they got even weaker as time went by if they didn't have it treated.
Can you run again after an Achilles tear?
Again, different technique of how it's fixed, if it's conservative versus surgical. And the other question is, how much of an athlete are you when it comes to running? If you're a runner before and you're treated either way, you should be able to go back to running. If you're treated in a conservative fashion, which is casting for the most part, non-surgical, you may still have some weakness. You may not feel like you're able to run. So therefore, most high athletes or athletes that are running and things, surgical repair is probably your better option to get you back running.
If you have a bad wound, what is done to help heal it?
And sometimes that depends on what type of wound it is. Other comorbidities, including if they're a smoker, you have to be able to control those type of events. So if they're smokers, you want to make sure they're not smoking. If they are having wound complications where the wound just doesn't heal, the question is there hypertrophy of the scar tissue, or there's any type of adequate blood supply in itself? Sometimes you have to go in and do consults with plastic surgery and get flaps to cover over that area itself, or you have to do muscle turn downs to try and get coverage and then have possibly do split thickness skin grafting over it. It can be very complicated sometimes to try and get that wound coverage.
Can I choose an endoscopic repair?
Yeah, I think the answer is that you can choose it. It's a conversation that I have with my patients. So again, there are some orthopedic surgeons who just don't do it. They're not, they don't feel very comfortable in it. In my office, you can have several options of doing nothing, doing conservative care versus surgical. From a surgical standpoint, I usually lean more towards the endoscopic repair.
Great. That was our last question for this topic.
Fantastic. So we're going to move on, and our next topic is going to be ankle arthritis. So when we talk about foot and ankle injuries, this is kind of a unique one because we're talking about arthritis, but with arthritis, it's very, very important to understand is with most injuries of in orthopedic world, especially in foot and ankle world, we're trying to protect the joint. When you have multiple injuries to the joint, the ligaments get stretched out, it can lead to stress to the joint space, inflammatory response, or even damage traumatically to the joint surfaces, which leads to arthritis. So what is arthritis? Well, it's Latin for inflammation of the joint. It's the leading cause of disability in the United States, and there's several different types, but all lead to destruction of the cartilage in the joint space. There's osteoarthritis and there's rheumatoid arthritis. Osteoarthritis is more wear and tear, somewhat genetic as well, but slow progressive loss of cartilage. With rheumatoid arthritis, the immune system is destroying the cartilage. Many joints are attacked at the same time for the individual. There's also post-traumatic arthritis, whether it be from fracture or multiple ankle sprains. There's one really bad ankle sprain can lead to arthritis. What happens with arthritis? Well, if you look at the cartoons, normal is on the left-hand side and arthritis is depicted on the lower right side. With normal cartilage, you see a pristine cartilage layer. It's thick. It has a good, stable, bony base, which carries its blood supply through the periosteum, which nourishes and supports the cartilage. It is a shock absorber. It's also a stress reducer. So any type of fluid within the joint space, the cartilage is able to displace the fluid away from the bone. When you have arthritic response, there's damage to the cartilage is no longer healthy. There's degeneration of the cartilage leading to delamination or flaking of the cartilage off, which exposes the bone to different types of pressure, and that leads to destruction of the bone or deformity of the bone, including cystic formation, but most importantly, is the increasing pain. And that's why people who have arthritis have increasing pain. This is another depiction of showing the arthritic response of the joint space. There's natural partners, but the synovium gets thicker with arthritis. And the synovium is the lining around the joint space. In addition to the capsule, the synovium gets thicker. That carries an inflammatory response. And the body starts to feed on itself, where the inflammatory response leads to another inflammatory response, which leads to destruction of the articular cartilage. With the destruction of articular cartilage, you get more pain. Here's another picture showing arthritic response. There's normal cartilage and there's arthritic cartilage. You see normal cartilage, it's thicker. It supports the joint space without collapsing down on itself. When you have arthritis where the cartilage has been destroyed, you lose the supporting structure of the cartilage, and the bone becomes more painful because now it's bone-on-bone deformity. And that's considered more advanced arthritis. What causes the pain? Once again, it's damaged and flaking cartilage. It floats in joint space. Mechanically, it can get caught in the joint at times. The ankle feels unstable because the patient is responding to pain. When you have pain and we're walking on our foot, it's a reflex. And if you have pain, your brain will interpret that reflex and makes you push your foot or ankle to get off. It's the same thing if you're walking barefoot and you step on a tack. Your ankle or foot will buckle to get you off that because of the painful response. With bone-on-bone contact, this is another source of pain. The ankle makes a grinding noise at times. There's swelling and stiffness and inflammatory response. The ligaments will loosen. The ankle feels unstable. Combine that with pain, people are very unhappy. Mechanically, bone spurs can occur and extra bone around joints. There's lots of ankle motion that occurs with this, but the spurs can hit each other, leading to severe pain at times. So what are the symptoms? Pain is number one, but they can have stiffness as well. There's be warning stiffness. The joint is stiffer and harder to move over time. There's swelling by the end of the day. Joint feels unstable at times and gives out. There's episodes of severe pain and joint locking. So we look at x-rays. On the left is more of a normal appearing X-ray, although it has an extra piece of bone, this aspect of the fibula bone, but the joint space of the ankle is maintained. When you start to get a little bit of arthritis, you'll see spurs starting to form. The joint space is still maintained, might be decreased, but you're getting more spurs that are occurring in the gutters of the ankle joint. When you look at more moderate arthritis, the joint space is collapsing. Some of the joint may look somewhat normal, but part of the joint does not look normal. When you get advanced arthritis, the whole joint looks arthritic. You're getting cystic changes to the bone. There's no cartilage left in this part, and people are very uncomfortable. With MRI scan, what we're looking for is any type of osteochondral lesions. And osteochondral lesions where only isolated areas of the cartilage have been affected. But in this case, there's an inflammatory response not just to the ankle bone proper, but also to the shin bone, which covers the roof of the joint space. So this is called a kissing lesion. They're getting arthritic response to the top of the ankle joint, but also to the bottom of the ankle bone itself. What are the treatment goals with the treating of arthritis? That's really pain and inflammation, slow the disease progression, because once you have arthritis, it's actually destruction of the cartilage. So we're trying to slow the destruction of the cartilage down. We want to be able to improve the quality of life and restore and maintain functional independence as much as we can. How do we do this? There's different types of medications you can take. There's lifestyle changes, physical therapy, bracing, and eventually surgery. With medications, that includes pain relievers, whether it be through or opioids. But nowadays, we're trying to get away from these medications as much as we can, because they're really not treating anything from our arthritic standpoint except for pain. So this is a big area of concentration where we're trying to get people off of narcotics to be able to treat their pain. Medications, including non-steroidal anti-inflammatory medications, can be more beneficial because they control inflammation but also control pain. With nutritional supplements, including the glucosamine, chondroitin, and sulfate, these are natural supplements that people can take and help control swelling and pain. Fish oil or vitamin E act as antioxidants, and these are beneficial for controlling inflammatory response. Different type of joint injections, including corticosteroids. The newer ones out there include the hyaluronic acid. That's more common in the knee joint. That is typically not approved by insurance companies to go into anywhere else besides the knee joint, but it can be beneficial into the ankle joint as well as the shoulder joint. When it comes to some of the biologics, platelet-rich plasma injection can be beneficial into the ankle. Once again, insurance may or may not cover this, but it can be a benefit. This is a picture showing a different type of injection that you're getting. Typically, this is approached in an office. It's fairly straightforward. Usually, we put some cold spray on there to envelop the area where we'll inject, and we place the needle in there directly. The problem with it, as soon as you inject around the joint capsule, that can be a burning sensation that people get. That usually lasts about 10 seconds. But also, when someone has advanced arthritic response, the joint is already inflamed and swollen. So then when you add fluid in there, it adds more pressure to the joint space, and that's uncomfortable for some individuals. But once it calms down, it can be very beneficial for them. What are lifestyle changes? We want to try to avoid impact activities when we have arthritis. That includes running or impact aerobics, treadmills, sometimes hiking. You have to be careful about certain things because it's not just arthritis. Remember, sometimes the ankle's unstable. We don't want to cause any more damage to the ankle overall. Non-impact exercises are very good, including swimming or water aerobics, hiking. Sometimes yoga can be a very beneficial exercise. Canes or walkers can be beneficial to offload the joint slightly. Weight loss. We see a lot of people these days who carry a little more weight than what they should be doing. That is a very difficult conversation to have with patients. Physicians just don't like doing that conversation. But as a physician, it's very important to have that conversation with someone. It's like, you have arthritis. It's not going to go away. It's going to get worse. We probably should get some weight off if those individuals are appropriate. Physical therapies are one of the mainstays we use for helping people. It improves the ankle motion with different types of stretching routines. It improves strength in the ankle overall with non-impact exercises. You can do TheraBand exercises as well, and we usually give someone a home exercise program. With the range of motion maintained, that can decrease pain and swelling. You can do different methods as well, including electrical stimulation that's provided in physical therapy. Heat and cold therapies can be a benefit. Massage or barrage can be a benefit with physical therapists as well. Different bracing options are out there, including shoe modifications. There's non-fixed supportive braces, including the typical lace-up ankle brace, but even just compression wraps can be a benefit for a lot of individuals. The fixed supportive braces are more restrictive. That includes posterior splints or AFO, which stands for ankle foot orthosis, or even circumferential braces like an Arizona brace, which is a custom-made brace made out of leather. It's very restrictive, but very helpful for a lot of people who have advanced arthritis. So these are non-fixed supportive braces, including cloth lace-up ankle brace versus a plastic hinge brace. These can be very beneficial to people who just want to get an irregular tissue and have some support to their ankle. These are more the advanced type of braces, including a posterior splint, otherwise known as an ankle foot orthosis or an AFO, and a circumferential brace, usually made of leather, laced up. It's called an Arizona brace. Two modifications include rocker shoes or even lifts in their heels so that their range of motion is supportive of what heel counter they have. When it comes to surgical treatments of ankle arthritis, there's arthroscopic debridement, which is something you can do if you have a loose spot in the joint space, small spurs that are in the joint as well. All this is designed to improve on pain and maintain function. When people have more advanced arthritis, then the options include either arthrodesis, which is otherwise known as fusion, versus arthroplasty, which is a joint replacement. With arthrodesis, it's usually you're saved until you have advanced arthritis where the patient's pain warrants doing this procedure. However, with you fusing the joint, it fuses the joint into a single bone, so the motion is lost. The pain is recovered. There's a good outcome and long recovery from the surgery, but most importantly, their pain is subsided. With a joint replacement, they have advanced arthritis. You replace the joint with the implant. You maintain their function, the motion of the joint, but you also relieve them of their pain. This is a picture doing arthroscopic debridement. Basically, it's three small poke holes. You put a camera inside the joint space, and through these three small poke holes, you're able to relieve people of pain, discomfort from either loose bodies or inflammatory response from the joint space. Here's some pictures inside the joint space from the medial talus as well as the lateral talus. This is more of a normal periankle. Some people have loose bodies or osteochondral lesions, and here you can see we're retrieving those loose bodies. We can also take care of these isolated lesions and make small little holes in the bone. It's called microfracture, and that gets the bone to bleed, and that fills in with blood clot, and that blood clot will eventually form fibrocartilage, which covers over the isolated area of the osteochondral lesion. Although this is a form of arthritis, here we're trying to repair the arthritis. It's very unique. We can't do that with everybody. This is a picture of ankle fusion. Here we've removed the joint surfaces where they were arthritic and made approximating joint surfaces. Then we put screws across those joints to allow the bones to grow together. Once the bones have grown together, the hardware doesn't serve a purpose anymore. Again, you lose motion with this case, but you'll have relief of pain. There's a metric line of an ankle fusion as well. With an ankle fusion, they always walk with an altered gait because they typically have a little bit of a shorter leg. The success requires joints below and in front of the ankle being normal. 100% of arthritis rate at 20 years in other joints. So if you have an ankle fusion and within 20 years, you will get arthritis from other joints of the foot. That's 100% indicated. And there's a fusion rate of 83%, which means 17% of the population, their fusion doesn't go very well. It doesn't heal the right way. An average of 17.5 weeks to solid fusion. So it takes a little while for this to heal. Some people still have residual discomfort, anywhere between 8 to 20%, and 2% lead to amputation rate for salvage. So it's not without risks. Complications include malunion or poor position of the ankle itself. There's also non-union or failure of the bones to fuse. Both will require another surgery to fix them. When we talk about ankle replacements, there are different types of ankle replacements. Here's just a couple of them that I typically use. Again, we're trying to replace the joint surfaces with a new metallic implant and then a plastic spacer, otherwise known as a bearing. With ankle arthroplasty, the whole goal is to get the patient walking again with function to their ankle, be relieved of stress and pain, and to hopefully take the stress away from the other joints so they don't lead to arthritis. So the wound may have trouble with ankle arthroplasty. It's one of the most common concerns. So we have to be really protective of that wound itself. There's newer ways we're doing things to help control that wound environment. Infections are a concern with any type of joint replacement. So we're very careful about how we take care of these arthroplasty patients and make sure their wounds do not have risk of complications, including infections. With arthroplasty, the parts may wear over time, and sometimes the results are anywhere around between 15 and 20 years for ankle replacements. But even then, sometimes all we have to do a revision arthroplasty is go in and take the plastic out as long as the metal components are stable. Take the plastic out and put a new polyethylene bearing back in. With ankle arthritis, they have very good outcomes, but it does require a surgical skill level, which means that the orthopedic surgeon has to feel very comfortable doing these type of procedures. I think for an ankle arthroplasty, from my standpoint, when I still do knee replacement things, the ankle replacement is still one of the most difficult arthroplasties to do. So joint replacement versus fusion. Joint replacement, again, you enable motion still to the joint space, provides predictable pain, can correct significant deformities in the ankle when it has advanced arthritis. Moderate non-weight bearing heal time 2 to 6 weeks. There's about a 60% revision rate at 5 years, but it may require device replacement and 90% survivability of implant at 10 years. But now we're pushing that out in between 15 to 20 years. With a fusion, it locks the ankle in a fixed position. It's predictable how it will relieve the pain, but once again, it takes away the motion. It can correct significant deformities of the ankle joint. Prolonged non-weight bearing healing time, anywhere between 2 to 4 months. There can be a 10% non-union rate. It also may lead to arthritis in other joints of the foot. So it's been endorsed by various academies throughout the United States. It's rapidly becoming very readily accessible by most insurance companies. The position statement by the American Academy of Orthopedic Foot and Ankle Society, the use of total ankle replacement for the treatment of ankle conditions that are arthritic can result in substantial pain and dysfunction. The American Orthopedic supports the use of total ankle replacement as an option for the treatment of ankle arthritis that has failed conservative management and select patients due to its demonstrated improved outcomes in multiple peer-reviewed publications. This statement had to come out because when we first started coming out with ankle replacements, it was not looked upon very well, and many people said that was not a proven ankle implant. And so the American Orthopedic Foot and Ankle Society had to come out with a statement saying, no, these are accepted now. This is the right way of taking care of ankle arthritis. So there are several types of ankle arthritis, but all have cartilage loss as the main problem. Arthritis is painful but treatable. There are a variety of treatment options. The first step towards recovery is a review of your condition. You should talk to your doctor about your options and learn as much as you can online, but be careful about the information you find online as well. This is my team that we utilize here in my office that you may come across. Thank you. Questions for me, Heather?
Yes. Can you prevent arthritis?
It's a good question. Some people are prone to have arthritis from a genetic standpoint. But I think overall, you can prevent arthritis by controlling weight. You want to be able to control any type of trauma to that lower extremity, especially when we're talking about foot and ankle arthritis. Those are the mainstays. So when you start having arthritis, you have to recognize it. So if you have an inflammatory response to your ankle joint, is that arthritic? Yeah. Anytime you have inflammation in your ankle joint, you want to be able to control it. So you have to start early. I'm not sure once you have arthritis, you can make it go away. Technically, you can make a case that, well, if you have inflammation, get the inflammation to calm down and go away. That's true, but there may be still an insult that's happened to the joint space, which may lead to arthritis further down the line.
How common is ankle arthritis, and can you get arthritis in your foot too?
Yeah, ankle arthritis is fairly common, especially in those individuals who've had ankle sprains previously. And those people who have had ankle sprains multiple times throughout their life, they're more prone to have arthritis. So many times I've had patients in the office that come in around 40 to 50 years of age, but they had a really bad ankle sprain when they were in high school and it was never treated appropriately. And it led to arthritis when they were 40 or 50 years of age. And that's a concern. That's why we want to be really careful about the younger individuals who have ankle sprains or have multiple ankle sprains. We want to take care of them, we want to store the joint space, make sure it's stable so it does not lead to arthritis in their later years. When it comes to can you get ankle arthritis in the other parts of your foot, or arthritis or other joints in your foot, if you have ankle arthritis, yes, because the motion is restricted to your ankle, the body will pick up that other motion plane in different parts of your foot, which leads to arthritis to other parts of your foot because your ankle has primary arthritis.
The next question is, what is PRP?
PRP is one of the newer things. It's a biologic. It stands for platelet-rich plasma. It's an injection given these days. It's usually done as an outpatient, usually in the office or even sometimes at a surgery center. It's your own blood, and we siphon that off, and we take different amounts of blood in different preparations. But typically, it's about anywhere between 30 to 60 cc's of blood. And you spin it down in a centrifuge, and that layers out the different levels of blood. And one of those layers is called the platelet-rich plasma layer, and that's the body's ability to heal itself. It has platelets inside of it, and once it's concentrated, then you can deliver it through injections. And it's usually injected into either tendons or things that have gotten hurt that you want them to get to heal. And we don't have a lot of data out there right now as it comes to PRP applied into joints. It doesn't cause damage per se, but it does set off an inflammatory response. And so we're leaning more towards PRP about what it's able to do for us. But when we're trying to get things to heal, PRP can be very beneficial for us. But just to inject willy-nilly the PRP into someone's joint space, we're asking a lot for that to just cover over the arthritic response and get to fill in. I'm going to dive right in now to the biologics out there, because you guys may have heard all the things about stem cells, mesenchymal cells, and different types of preparations where you gather from the human body and just inject it in the joint space to try and relieve people of arthritis. You may even hear some things on the radio these days. That doesn't work. There's not research about there. It's not accepted by the American Academy of Orthopedic Surgeons, because just to inject something in the joint space to make it turn into cartilage, even though it has the ability to turn into cartilage, there's nothing that we know of to selectively apply it to the area that has arthritis, nor for it to gain a blood supply, which is the most important thing we have for those cells. They have to regain a blood supply, and then we have to turn it on to that specific type of tissue. So it's very concerning that it's being put out there. We have to be a little careful about what we're promoting and let patients know that this is what really works when it doesn't work. We need more research on how to prepare it and how it should be applied to patients.
Is PRP covered by insurance?
I think different insurance may cover it, but I think most do not. But you can still pay cash pay for it.
Can I do PT near my house?
Yes, if you have physical therapy near your house, you're more than welcome. I usually recommend you see a licensed physical therapist, not a chiropractor, not an athletic trainer. We usually want you to go see a physical therapist so they can follow you and map out your program for you, and then give us some reports about how well you're doing and any concerns they may have.
Is there any particular brace that you recommend?
The powerhouse is the ASO ankle brace, which is a slip-on lace-on brace. It's got straps that go around it. That's usually the one that I usually use. It gives patients support enough that they can wear it in a tennis shoe and carry on with their activities.
Is an ankle fusion or replacement better?
I lean more towards an ankle replacement because it maintains the function of the ankle joint. It relieves patients of their pain, and it decreases their risk of getting arthritis to other joints. Ankle fusion will do the same of controlling pain, but it's going to take away motion and add more risk to those other joints.
And are there any additional questions? No? Okay. Thank you very much, Dr. Gittins. Thank you for participating in tonight's webinar. Our next webinar will be held on July 8th. Dr. Ralph Napolitano will speak on keeping your feet healthy this summer. Enjoy the rest of your evening. Good night.